I'm joined by our fearless leader, Yosef. So how are you doing, Yosef?
Good. I'm also part of the CP Solvers team. I'm so excited to join the session today, Sarah.
And these sessions tend to be very interactive. We love being able to hear the voices from the chat, as well as your like expertise and discussion. So we thought we'd start out like with a little bit of a breakout, like a quick breakout session, just so that we're all warming up to each other this morning. And the icebreaker question that we wanted everyone to discuss was, which superpower would you prefer? Is it either to, Yusuf, remind me which ones it was.
The options were either you can be invisible on command or you're able to fly. And introduce yourself, obviously. Okay. And we're going to do just like 1 minute of that, or 2 minutes. Andrea, imagine you have the power of flight and then you just go chill in another country. Like everybody knows you have that superpower. And they're like, what is Andrea doing? Like sitting on the beach.
I mean, that would be nice. I could take boring meetings from work somewhere nice, like choose a different beach every day.
There you go.
Or go to Italy and have like a nice small coffees, like here in the US, you cannot really find good coffee. Everything is burnt. Sorry to say, guys. It's hard to find good coffee in the US.
Okay, well, welcome back, everyone. Sorry for the small interjection. It was definitely fun for our group. We have a case for you all today. I'm not sure if someone is taking teaching points this morning, but we can start with the brief case and then we can figure it out. So
I'm describing.
Oh, yes, amazing, Yasmin. Let me give you a co-host. Perfect. Thank you so much. So this is the case of a 73-year-old female with a history of COPD, major depressive disorder, a 60-pack year history of tobacco use, presenting for shortness of breath. Let me give you a little bit of more history. So the patient reports 2 weeks of worsening dyspnea on exertion, along with new onset cough. They have increased sputum production that is white and subjective chills over the last week. They report a mild left-sided chest pain, palpitations, and decreased PO intake. Despite taking the inhalers, she feels that she's still having these symptoms. And she denies having any bendopnea, orthopnea, paroxysmal nocturnal dyspnea. And she does report that she's been using her inhalers more frequently than prior. Sarah, I'm going to give it to you.
Okay. Well, thanks, Yosef, for presenting that the beginning of the case. And then, as you all may know, that these sessions are very interactive, so we'd love to hear your thoughts. And so the first question that I'd like to ask the group is, what is your differential diagnosis for this patient's dyspnea? And what is your most likely diagnosis based on this history so far? And feel free to type in the chat, feel free to unmute yourself. Yeah, I'm seeing an infectious process sounds suspicious, like pneumonia, acute exacerbation of COPD, cardiac versus non-cardiac, and I'm seeing a lot of COPD exacerbation. I'm curious, what, if someone can unmute and share, what about this case makes you think COPD exacerbation?
Hi. Can you hear me?
Yeah.
I think it would be COPD exacerbation because of the acute symptoms of the dyspnea, the cough, and sputum production with the cough, the chills. So the chills, well, depending on the vitals, if she has a temperature, she could be having an infection that could be worsening her or causing an exacerbation right now.
Yeah, incredible thoughts. And that, yeah, exactly what we were thinking too. And then based on the GOLD criteria definition of COPD exacerbation, this patient fits the case. The GOLD criteria defines COPD exacerbation as a clinical diagnosis of increased cough, sputum production, and dyspnea over a course of less than 14 days. And it's often associated with some kind of trigger like infection or pollution or other insult to the airways. associated with local and systemic inflammation. So exactly right, infection could be causing this person's exacerbation. And you noted things on the physical exam that we could be looking for, things like wheezing, tachypnea or respiratory compromise, things like altered mental status as a result of hypercapnia. So yeah, great thoughts, Aisha, thank you. And then the next thing that I wanted to ask about was, I heard some cardiac versus non-cardiac from Bea in particular. I was wondering if you could if you feel comfortable unmuting and sharing what kind of cardiac condition would you be concerned about in this case?
Well, I might consider ischemic heart disease, so angina, but also myocardial infarction, arrhythmias. And that was what I was thinking on when I said cardiac causes. But again, it could also be non-cardiac causes. So an exacerbation of COPD, or I also later thought that you mentioned this patient was having chills. So that might give a hint of an infection going on potentially. I mean, if I wanted to further consider the heart hypothesis, I would ask for an ECG and to assess potential cardiac arrhythmias or an evidence of myocardial ischemia. But yeah, I was thinking about this.
Amazing thoughts. Yeah, definitely MI and ischemic cardiac disease is a can't miss diagnosis in this case. So we'll talk about that a little bit later when we talk about how to work up an acute exacerbation of COPD. I was wondering if anyone was thinking about the relationship between or the difference between COPD exacerbation and heart failure exacerbation, because those can often be on the same differential. I know Deborah, she talked about bendopnea, which is related to heart failure exacerbation. I'm wondering if you had thoughts about how COPD and heart failure could be related to each other.
Yeah, the bendopnea, I was writing in the chat that I listened recently that we associated with heart failure on the left side. But like in the podcast, they said that could be like some infections or some pulmonary hypertension too can be associated. But thinking about the COPD and the heart failure, I think the dyspnea, it's something that crossed my mind that could be present on both. And I think more about the difference. Like I think on a heart failure exacerbation, I'll look more for edema, for regurgitation of the vein. Yeah, I think I there are some things that could be similar, but I think the most similar thing that crossed my mind will be the dyspnea. And then we go see the patient. Of course, this patient, we need to check if has like any heart failure or any disease out in the heart, and the past medical history of tobacco make us think more about COPD. I think that's where my mind goes.
Yeah, thank you so much for those thoughts. You actually like read exactly my mind for the teaching point that I wanted to highlight here, the relationship between COPD exacerbation and heart failure exacerbation. COPD is related to right heart failure or cor pulmonale, as someone in the chat expertly pointed out, because of the hypoxia causing vasoconstriction and leading to right heart strain. So you have right heart hypertrophy and then eventually right heart remodeling and leading to right heart failure. So thank you for pointing those out. And you also expertly pointed out the differences in physical exam that we'd see in COPD. You'd normally have CO2 retention and acidosis and wheezing, and then CHF exacerbation, you'd have like bibasilar crackles, evidence of volume overload, and respiratory alkalosis instead of acidosis because of hypocapnia. So yeah, thank you for sharing your thoughts. And a lot of people were also talking about the different triggers for COP exacerbation, like the infectious causes. I was wondering if someone would be open to sharing what the common triggers for acute exacerbation of COPD were.
Okay, hello everyone. So in regards to the trigger, to be honest, what comes into my mind is viral and bacterial origin triggers. And I remember studying it as well as that Pseudomonas and MRSA seem to be the most common. And this is why you need to initiate antibiotics that target these specific organisms, including respiratory fluoroquinolones. You could also consider cephalosporins and macrolides. But also an interesting trigger that I've come across recently that a patient had on our wards was pulmonary embolism. And I read about it a little bit, and it seems that patients who have pulmonary embolism as a trigger of their exacerbation for COPD seem to have worse outcomes than those with infectious origins.
Yes, thank you for sharing, Ibrahim. And you also read our minds of a teaching point that we're going to bring up later about the pulmonary embolism. So thank you for sharing. And indeed, you're right. The infectious causes are quite common. How we commonly think about causes of infection, viral is going to be greater than bacterial in this case, but infectious causes account for about 70 to 80% of acute exacerbations. So including viral like rhinovirus or influenza, bacterial like H flu, strep pneumo, which someone pointed out in the chat. And then those are more common than atypical bacterial like Pseudomonas. And then the rest of the 20 to 30% of cases can be due to pollution, non-adherence to medication, like this case, GERD, aspiration, and also PE. So thank you for sharing those thoughts. And I think to round out our initial case presentation, I'll give it back to you, so to give some more physical exam information.
Yeah, thank you. So on vitals, the blood pressure is 115/60. The heart rate is 113. The temperature is 37.0. The respiratory rate was 20. The oxygen saturation was 93% on 2 liters of nasal cannula. On exam, the patient was awake, alert, and oriented ×3. They were in mild respiratory distress in that they were having mildly increased work of breathing with a bilateral wheezing on exam. The heart sounds were without any murmurs, but they were notable for tachycardia. And the abdomen was soft and non-tender. The lower extremities did not have any edema, and the extremities were warm, and there were no rashes on exam. And just for everyone joining us today, this was actually modified from a real case that I saw a couple of weeks ago. And these were like from a real life example, and I just modified it for HIPAA purposes. So at this point in time, I was thinking of a COPD exacerbation as my number one on my differential. And we started with EKG and a chest X-ray. The EKG was notable for sinus tachycardia without any other abnormalities, while the chest X-ray, we're going to post it on the document shortly. Yes, if you can post it, that would be good. Now, at this point in time, we're going to see the chest X-ray, but it's notable for hyperinflation, and mild perihilar infiltrates, but no lobar infiltrates per se. And I had a poll for the crowd, is that now that we discussed pulmonary embolism, how many of you would order a CTPE at this point in time? And I'm gonna send the poll now, if you can vote on that.
Is there any leg swelling at this point?
No leg swelling.
I'm curious, Pallavi, if you could share why you ask about that.
So this is a 76-year-old person, may have some mobility issues, maybe more sedentary. So I'm suspecting like a DVT, possibly that could point you towards a pulmonary embolism, if that's what we're thinking of in terms of shortness of breath and tachycardia with that picture. But I also recognize that that's not always, you wouldn't rule that out just because you don't see a leg swelling. But to the poll, I answered no. I wouldn't test for a PE at this point.
I love it. Thank you. So we're gonna break into breakout rooms in a second. The only thing I wanted to mention that the poll result right now is 48% would get a CTPE and 52% would not get a CTPE. So it's pretty even. We can break out into breakout rooms, and the thing I want you to answer is, what things make you think that this patient has a PE? And what thing makes you think that this patient does not have a PE? Or what are the for PE and what are against PE? The poll now is at 50-50. We're split down the middle. So let's break it down, and then we'll come back to discuss. Welcome back, everyone. I was wondering if we can get a volunteer to tell us what are the factors that make you think that they have a PE, or what are the things that are leading you towards PE? If anyone can let us know.
I can go. So for our group, we are Team CTPE. The patient is old, she has underlying COPD, she's probably sedentary, she's hypoxic, the chest X-ray is normal, and the D-dimers can be elevated for other reasons other than the PE. So if it is positive, we can't really rule it in, although it has high negative predictive values. So the CTPE is a very good next step given like the data that we have.
And I'm wondering if we have anybody whose team hold off for now, who wants to talk to us about that.
Hey, Yusuf, I can summarize. Well, first of all, we had varying thoughts, but I think the presence of wheeze could be reassuring that we have something to treat right now, because presumably that would be related to a COPD exacerbation we haven't yet treated, but we definitely recognize that if they didn't get better with standard COPD treatment, that we would then start to begin thinking about PE rollout.
I love it, Andrew. Thank you. I started another poll to see if that changed any of your opinions, but we'll get to the results shortly. So this was an actual debate between me and the attending I was staffing with. Like this was overnight. I had an admission, and we were discussing whether to get a CTPE or not. So the percentage of patients with acute exacerbation of COPD who have a pulmonary embolism is 30%, up to 30%. So it's relatively high. And however, a lot of the findings that we have are confounded. The tachycardia could be secondary to the acute exacerbation of COPD. The hypoxia could be due to the acute exacerbation of COPD. All of the findings that we have could be caused by something else. So diving a little bit into the first of all, what a confounder is. In research, the world of research, a confounder is a variable, is a third variable that affects the cause and the effect. An example for that is, for example, the number of people eating ice cream per season is associated with the number of jellyfish stings per month. So if more people are eating ice cream, there are more jellyfish stings per month. But if you stop for a second and think about it, the confounder here is the warm weather. And that if there is warm weather, more people are likely to eat ice cream and more likely are people are to swim, and therefore the number of jellyfish stings will also go up. And that's what we call a confounder. That is significantly discussed, for example, in medicine when we talk about race, for example. Race is oftentimes misattributed as a cause for multiple illnesses or associated with illnesses, but oftentimes there are residual confounders that if you account for, race would not be associated with those particular illnesses per se. So the GOLD criteria, the 2023 update, mentions that the things to think of in acute exacerbation of COPD are pneumonia, heart failure, and pulmonary embolism. There are multiple risk scores that can help you in this situation. A few I can mention are the Geneva score, the PERC rule, and the years algorithm. These are 3 algorithms that help you think of what's the risk that my patient has a PE. If you use Geneva, for example, this patient would be higher risk. If you use PERC, the PERC rule was validated to rule out PE, but not to rule in. So it doesn't tell you if the patient has a PE, but it tells you if you can skip or hold off getting imaging, for example. The years algorithm is actually one that I really like. It's basically the Wells score. In addition, it incorporates the D-dimer. So it gives you a different D-dimer cutoff based on the risk that they have. And that's what we ended up doing in this case. So I was discussing with the attending, and we were like, why don't we get a D-dimer? Like Umayma said, it might be elevated. And this was a debate between us too. And we're like, it might be elevated, but let's get it now, because if it is low, we might be able to rule out PE safely. So we ended up getting a D-dimer, and it ended up being 450, and that was lower than the limit of normal. So we held off getting a CTPE at that point. But I want to clarify that there is no right answer in regards to getting a CTPE at this point. There's just risk scores to assist you in deciding, and there's no one answer whether to get the scan or not. So Sarah, throwing it back to you in regards to approaching high-value care.
Oh, yes. Thank you so much for sharing. And I would love to know, before the question that I want to ask the group is, what if you were in a resource limited setting, what kinds of tests would you order and why? But I'd love to hear first from someone who posted in the chat about, I would decide on the CTP after labs. Razaz, are you in a place where you can share what kinds of labs you'd want to order first?
Hi, I'm gonna start with general labs. I'm gonna see her CBC for any infection. Also the RFTs, the LFTs. I'm gonna start with general labs. The ABG is really important too. I'm gonna order the D-dimer. Yeah, I'm just gonna start with general first to rule out infection.
If I can, I would think of the VQ scan if like that the respiratory distress persists. But now there is a low D-dimer, so why even think of that, honestly? Inhalers, was she only using like short-acting beta agonists? What was she using, inhalers? With the understanding that we don't have more data, but still.
Yeah, short-acting beta agonist and with a steroid inhaler as well.
Yeah, and I would also love to review her medications, if she's on any medications.
Yeah, all great thoughts. Definitely want to get basic labs for looking at whether or not she has an infection, looking at D-dimer to see if she's at, if that can help us determine if she has a PE. I'm seeing a lot of ABGs in the chat and ECGs to look for ischemic disease or right heart strain, and then ABGs to look at oxygenation, BMP for heart failure exacerbation. So yeah, thank you for all your thoughts. The VQ scan, I'm actually not so familiar with, so I'm wondering if anyone else has expertise on when it would be appropriate to order the VQ scan.
The VQ scan is usually helpful in scenarios, for example, where you want to avoid contrast. That's one indication if you're worried about kidney dysfunction, or if you have inherent if you're still worried about PE and you have limited access to a CTPE, that's a scenario where you can use a VQ scan, for example.
Thank you for sharing that information. That's a learning point for me from this case. And I see Jamil also put procalcitonin as one of the labs that they would want to order. I'm wondering if you can share your thoughts on what that would add to this case.
It was for the to rule in or rule out infection as a cause, especially bacterial infection, because infectious cause upfront can be ascertained once VET. I mean, we are not sure of pulmonary embolism.
Yeah, thank you for sharing your thoughts. And that's actually perfect because there are a couple of studies that we can get to work up acute exacerbation of COPD, that if we're in a resource limited setting, we may want to think about what value that they would add. So procalcitonin is something that a lab value that is used to determine if there's bacterial infection, so if antibiotics would be appropriate. But studies have shown that there's a 20% decrease in antibiotic use in one RCT, but there's no clear clinical evidence about whether or not that adds value to clinical judgment alone. So even though it reduces antibiotic risk, not 100% sure what it adds in the acute exacerbation of COPD. Other things that we sometimes get that we may want to rethink in a resource limited setting are viral panels, because it wouldn't necessarily change our management unless there's suspicion for influenza. Chest x-ray in the outpatient setting can be useful if there's pneumonia or heart failure exacerbation present, but doesn't add significant value in acute exacerbation of COPD. And then sputum studies take a long time to come back and may not change management unless there's concern for pseudomonal infection or someone who's not improving with empiric antibiotics. And so in the realm of antibiotics, I saw a discussion earlier about what kinds of antibiotics would be appropriate and who should get antibiotics. And based on the GOLD criteria, the most up-to-date, they suggest empiric antibiotic treatment in patients with COPD exacerbation with 2 out of 3 of these symptoms. So increased dyspnea, increased sputum volume or viscosity, and increased sputum purulence. So those are signs that there may be a bacterial infection present, or if there's a COPD exacerbation requiring hospitalization or ventilatory support. Interestingly, I found that if there's new onset wheezing, and that's the predominant feature of the presentation, it's less likely to be a bacterial infection, so antibiotics may not be needed. And of course, we would also give antibiotics if there's concern for concomitant community-acquired pneumonia. And in terms of choice of antibiotics, at least for up to date, I'm not 100% sure how this works in other countries depending on susceptibilities or areas depending on their susceptibilities, but the GOLD criteria recommend azithromycin first to decrease the mortality of the COPD exacerbation over a fluoroquinolone or a tetracycline. All right, and then I'll pass it to you, Yusuf, for the other medications.
Yeah, thank you. So going back to our case, and at this point we wanted to initiate some treatment. The general framework for approaching an acute exacerbation of COPD includes bronchodilators, so beta agonists and ipratropium, for example, which we call the Branfer's duanebs, corticosteroids, oxygen management, and including non-invasive positive pressure ventilation, and antibiotics, like Sarah said. And one thing you can consider as well is antivirals. So if you can test for the flu, for example, and turns back positive, you can treat with oseltamivir. I have a poll now for the chat as well. Let me write it now. Of those that are that I just mentioned, which one do you think was proven to have a mortality benefit? So the options are bronchodilators, steroids, IV antibiotics, oxygen, and non-invasive ventilation. The answers are very, very spread out. We have about 20% for each of the components, which I love, which shows that there's a lot of room for growth and teaching for everyone. So the thing that that has been studied in a randomized controlled trial and showed to have a mortality benefit is actually non-invasive positive pressure ventilation. Even though all of these components help with length of stay, preventing intubation, for example, the thing that has mortality benefit is non-invasive positive pressure ventilation, or BiPAP. So I'll get to the indications to BiPAP shortly, but BiPAP is a device that can provide positive pressure, and we call that there's two measures to it. I'm not gonna bore you with it. There's an IPAP and an EPAP, but basically it can provide a positive pressure to help with oxygenation. And there's also a gap between the IPAP and the EPAP that can help you blow off the CO2. And these are the two big things I want you to think of, is you can use the BiPAP either to improve oxygenation, or the major indication will be to help blow off the carbon dioxide. So this patient's VBG returned at 7.29 and a PCO2 of 70. Does anybody have like a quick way to convert a VBG to an ABG, or how do you approach these numbers?
So I think for the pH from VBG to ABG, you add 1. And then for the CO2, you subtract 10. And then on VBGs, the oxygen doesn't really mean anything. But you can correct me.
Yeah, so the VBG is from the veins, so the blood already went through the entire body, so you expect more CO2 because the cells are releasing CO2 than the ABG. So you expect it to be more acidic. And there is a correction for VBG of adding 0.04 to the pH and subtracting 8 from the CO2 level. However, there's a new review of the literature that shows that the VBG CO2 might be very variable, and that the changing between a pH on a VBG and an ABG might not be necessary. So in the past, we always did that for all VBGs. We would correct with 0.04 and add 0.08, although this might change in the future. So just adding that to your armamentarium. So in this case, we ended up getting an ABG as well. And I have the results here. This is going to be a hard question, but does anybody want to comment on the acid-base status? The pH is 7.33, the PCO2 is 60, the oxygen is 65, and the bicarb is 32. Love that. Laura, would you want to discuss? If you're able to. If not, it's okay. Or Hans.
Yes, looking at the pathology of COPD, that the patient is not able to blow out his CO2, and in an exacerbation that's even more exacerbated. So we have CO2 retention, giving rise in the end to a respiratory acidosis, which is partially corrected by the kidney.
And what do you all think of the bicarb?
It is higher because the CO2 is higher, and the bicarb actually increases the pH a little bit.
Ala, are you able to unmute or not?
Yes. I learned that with acute respiratory acidosis, with each CO2 rise, about 10 rise in CO2, there will be 4 rise in bicarb. This means that it is a chronic condition. And if it's only 1 rise in the bicarb, this means it's an acute condition. Here for the CO2 rise about 2 times, 2 plus 2 multiplied by 4, 8. 8 with 24 in the bicarb is 32. So I think it's chronic respiratory acidosis compensated with complete compensation.
Thank you, Ala. I didn't mean to make you do math on the spot, but that was amazing. Like Ala said, the bicarb usually takes time to rise because the kidneys take time to compensate for a chronic respiratory acidosis. So usually if you see a bicarb that is elevated, you think of more of a chronic process. Now, when we see this, these values, are we thinking, oh, is the CO2 high normal for this patient, or is it higher than their baseline? And one way to do that is to check their baseline bicarb level. And in this case, the baseline bicarb level, even if we go back in the chart, it's still 32. And based on that, like Ala said, for every 10 in CO2 rise, we expect a 4 in bicarb. So if the bicarb was 4 above 28, so then the CO2 should be around 50. And we see here that the CO2 is slightly above this patient's normal. So I want to bring to your attention that the patient's normal CO2 at baseline, because their bicarb is normally high, will be high. And the trick is to calculate, are they having an additional CO2 retention above of that? Another way to do it is just to open MD-Calc and write ABG analyzer. And you can literally plug in all of the numbers, and it helps you calculate the patient's acid-base status, which I consider like something we should use because we have it at our fingertips. So lastly, the thing I wanted to bring up was BiPAP again. The GOLD criteria of 2023 mentions that the indications for BiPAP are a respiratory acidosis. So either a PaCO2 more than 45 or a pH less than 7.35. Increased work of breathing, so signs of fatigue, increased work of breathing, paradoxical motion of the abdomen, retraction of intercostal spaces. And lastly, if there is decreased oxygenation. So if there is persistent hypoxemia, despite oxygen supplementation, those are the indications for BiPAP. There's even a new study that analyzes the use of BiPAP, and BiPAP or non-invasive ventilation is widely underused, even though it does have a mortality benefit, because it needs compliance from the patient. You need a respiratory therapist to help you with the device oftentimes. And it's not as prevalent, and we're hoping because of this, it can prevent intubation, it can prevent mortality, to spread the knowledge about the importance of use of non-invasive ventilation. Sarah, throwing it back to you.
Thank you. And thank you for going over the interpretation of the VBG, ABG. Unfortunately, in the clinical setting, we don't always have the option to draw very quick VBGs and ABGs. Often we're relying on the pulse oximeter, SpO2, as like a proxy instead. So I'm wondering if anyone can write in the chat what their target goal for SpO2 is in an acute exacerbation of COPD. And perhaps why. seeing 88 to 92%, 88 to 94%, 93%, 95%. So the target high yield point, the target goal is 88 to 92%, or 60 to 70 millimeters of mercury of PaO2 in order to minimize the risk of hypercapnia. And so the next question is, why do we have tried to lower our SpO2 target in order to decrease this risk? Like, why does this happen? Oh, the Haldane effect. Oh, perfect. Abraham, would you mind unmuting and sharing what that is?
Yeah, of course. Oxygen tension is in the blood, reflected by the. It's going to be the hemoglobin's affinity for oxygen. And so the lower its affinity is going to be for carbon dioxide, contributing to carbon dioxide retention overall.
Exactly. So if you have more oxygen, you displace the CO2, and then you have hypercapnia as a result. You also have that causes hypoxic vasoconstriction, increased VQ mismatch, and overall increased mortality and organ failure. So thank you for sharing those thoughts, Abraham. In addition, hyperoxia can also lead to more reactive oxygen species, which can be toxic to the lung tissue. And then the final learning point that I wanted to bring up is we're learning more and more that the pulse oximeters that we use can be inaccurately measuring is an inaccurate proxy for PaO2 in certain populations. I want to highlight this study that was done in the New England Journal of Medicine, which looked at patients who self-identified as Black and patients who self-identified as white, measured their SpO2 and then measured their PaO2 afterwards. And it was found that patients who self-identified as Black had a 3 times higher risk of occult hypoxemia and are at risk for higher mortality due to a discrepancy in their SpO2 measurement and their PaO2 measurement. We don't 100% know why this is true, but it is presumed to be as a result of skin pigmentation. And so what I want to highlight with this study is that, first of all, it is difficult to, it is a difficult study to interpret because race is used as a proxy for skin pigmentation. It doesn't acknowledge the diversity of different racial and ethnic groups. And as we as a field are attempting to move away from race-based medicine, we need to evaluate really carefully how we're using this data. But it can bring the consideration into clinical practice that if a patient has darker skin, you can consider targeting a higher oxygen target or getting an ABG to more accurately determine that patient's PaO2. And currently the FDA is working on new pulse oximeters in order to account for this phenomenon. So I think those are all of our teaching points that we had prepared. Thank you so much for your participation and your expertise. Yusuf, do you have any closing thoughts?
Yeah, like Andrew was mentioning in the chat. Andrew, do you want to share your thoughts if you're able to? If you can't, that's also okay, about the oxygen target level.
Yeah, no, absolutely. It's, super, super controversial. I brought this up on rounds before and people look at me like, like, what are you talking about? But there is a book I've read called the Landsberg Manual. Someone who graduated from Yale many years ago who wrote this Palm Crit textbook. And I've heard the option that in the acutely ill hospitalized patient with COPD, you may actually want to set a higher SAT goal, not saying 99%, but greater than 92% rather than the 88 to 92%, because the thinking is if you aren't achieving a PaO2 of 60, because below that you start having bad effects like worsening tachycardia, and those things can have bad effects like leading to worsening HFpEF, among some other things. The thought is that may actually be a bad thing, and the fear of hypercapnia and giving excess oxygen is actually kind of overstated, and that's very, very rare basically. So that was another kind of perspective on it, but I've never heard anyone else talk about this, just the thought I've heard.
Thank you, Andrew. I've actually heard this from a few of my attendings, they shared the same thought, but in general, you don't want your patient to be hypoxic, but you also don't want them to be at 100%. And choosing the right level will be between at least 88 and then less than 98, and it will be in that range, but different people will tell you different things. Sorry for ruining VBGs and pulse oximeters for you, but Ibrahim, do you want to take us away with the teaching points?
I think it's Noah.
Oh, it was Noah. It was Noah, sorry.
Yeah. Hey, everyone. So today we had a lot of teaching points. It was an amazing discussion. We first started with a patient with SOB. We talked about the differential diagnosis. For this patient with the history of COPD, we immediately thought of acute exacerbation. But I saw in the chat people mentioning pneumonia, heart failure exacerbation, MI, and PE. We briefly talked about how COPD can cause heart failure through the mechanism of cor pulmonale. Speaking more of the acute exacerbation of COPD, it is defined as acute dyspnea, cough, sputum, plus minus tachycardia and tachypnea, often with local and systemic inflammation triggered by infections or environmental factors or other factors like the PE. We had a poll to determine if this patient had a PE or not. Yusuf mentioned that those patients have a high base rate, so a high pre-test probability, but they also have many confounding factors which make the distinguishing features hard to appreciate. So algorithms can further help to further risk stratify this patient. So we mentioned Geneva score, PERC rule, and EARS algorithm. This is where the D-dimer also comes in handy. It helps to stratify and help us with the decision of getting a CTP or not. After we ruled out PE for this particular patient, we started talking about high-value workup. So basic labs, chest X-ray to rule out other causes of dyspnea. And the procalcitonin respiratory panels sputum studies are not routinely ordered. Although we do see them in the day-to-day, they are not confirmed to be high-valued care. Management-wise, we should start antibiotics and antivirals in select patients. Inhalers, of course, steroids and ventilatory support. Non-invasive positive pressure ventilation is the only one that has shown a mortality benefit, and it's underutilized. We briefly talked about the interpretation of ABG. So for every 10 in rise in PCO2, we expect 4 in rise in BiCAP. This is very useful to determine if this patient has more retention than her baseline. We also talked about the indications of non-invasive positive pressure ventilation. I'm not going to go over them again, but I'm going to leave them in the whiteboard. We talked about the target SpO2 for those patients. It's a point of discussion, but the widely accepted target is 88-92% due to haldane effect, VQ mismatch, and decreased drive in hyperoxia states. And we also talked about racial bias in pulse oximeter. So Black patients due to pigmentation probably have a higher chance of occult hypoxemia, but this is something that has to be further studied. And that's all I have for today.
No, that was amazing. If you had a channel narrating the teaching points, I think we would all join it any day of the week. I want to thank you all for joining this Saturday. I always have an amazing time, and it makes me so happy to see all of you like so eager to learn and like curious and wanting to learn new things every day. Join us on, if you're watching on YouTube, join us on VMR. You can sign up on the website, and we'll see you again for another session soon. Bye, everyone.